It's my pleasure to introduce our guest speaker for today, Professor Mayank Goyal from the University of Calgary. Um, Mayank is an old and very good friend. We were batchmates in medical college in All India Institute of Medical Sciences. We did our residency in radiology together. And since then, he's gone on to carve out for himself an incredibly successful and path-breaking career in the field of interventional neuroradiology. He did his fellowship at the University of Toronto, then moved to the University of Ottawa, and is most recently at the University of Calgary, where he is the Director of Research in the Department of Diagnostic Imaging. And Mayank is one of the smartest people I know, if not the smartest. And the thing that sets him out among his peers is that he has an incredibly innovative mind, and he applies this mind of his in every aspect of his clinical work. And this has led to some very groundbreaking research. One that is relevant to us and would be of interest to the technology people in the group is the project he did on the use of smartphone in the detection of acute stroke. And as we know, that is the potential to shorten the time for interpretation of a stroke CT very, very significantly. So that was widely published and received a lot of attention in the media. But most recently, he has been involved in a trial which made it to the New England Journal of Medicine. It's a multicentric trial which deals with the use of interventional neuroradiology in the acute treatment of stroke, and it has completely changed the way stroke treatment takes place now. And over the last 2 years, as he was telling me, he's been traveling around the world, giving lectures and training people in how to deploy these techniques. And the whole field of stroke care has been changed because of this groundbreaking research of his. So we are very, very fortunate to have him here with us today in PRS and RxDX, and I'd like to invite him to come and speak to us about the recent trends. Over to you.
So, good afternoon, everyone. Thanks, Arjun, for a kind introduction. And yeah, Arjun and I go back. 1984 was probably when I first met him. So, what, 31 years that we've known each other. So, it's a long, long time. And it's always a pleasure to come to Bangalore and catch up with old friends. I've been traveling around Bangalore since yesterday, visited a few hospitals. It's a pretty amazing city. I've come to Bangalore, probably this is the third time, and it's obviously a city that is still growing. So it's great to be back here and talk about some of the stuff that I'm doing. There's going to be quite a bit of information in this talk, and part of it is for you to get a flavor of the overall big picture, and then we sort of focus down a little bit on imaging, and then I'll go back up to the big picture again. So the initial part I'll run through relatively fast, and you'll start to get sort of a flavor of what the main results of the trials were. So these are some of my disclosures. I ran two trials, Escape and Swift Prime, and I'm going to talk a little bit about something that I've developed, and I'm trying to sort of make it into a commercial product. And then there was this third NEGM paper, Revascat. We were the core lab, so we read all the CTs, MRs related to it. So I was sort of probably out of all the trials that you'll see, I was probably the guy who was most intimately connected to most of the trials in one way, shape, or form. This was the one that we led out of Calgary. Michael Hill here, Andrew Demchuk, three of us, we designed the trial. We ran it together from Calgary. It was a worldwide trial in multiple different countries. And this is the paper that came out as a consequence. So this was released, this paper came out on February 11th this year. And because of the multiplicity of the trials, so this is the day that endovascular treatment, now this is written here, endovascular treatment became the standard of care. So for those of you who are unaware, so let me just give you sort of a 2-minute spiel on endovascular treatment. So essentially, a big acute ischemic stroke is due to blockage of one of the big vessels in the brain. And 20 years ago in 1995, an NEGM paper came out which showed the benefit of giving IV TPA compared to not giving IV TPA. But the problem is that IV TPA is not very effective in big occlusion. And somewhere along the way, we started doing this procedure under X-ray guidance, where you went in from the groin up into the blood vessels, went into the brain, captured the clot, and pulled it out. And this had been we've been sort of working on it, and we felt it was time to sort of prove that it works. And this is the result of that sort of so-called experiment, a randomized controlled trial. And this is the main result of the trial. In the treatment arm, 53% of the patients had good outcome, while in the control arm, 29% of the patients had good outcome, which translates to an approximate difference of 24%, which translates to number needed to treat of 4. And just to put it into perspective, number needed to treat of 4 is like as good as it gets in the field of medicine. So you probably heard of some relative getting an acute coronary syndrome, heart attack, going to a hospital and getting an urgent procedure, which is angiographically done. Just to put it into perspective, the NNT for a cardiac procedure is somewhere between 29 to 40. So that is how much more effective this procedure is in terms of benefit to patients compared to acute coronary syndrome. And you'll see a lot of slides that I'll show you this way, and this is a standard format for showing results in a stroke kind of trial. So the way that this slide works is that this is the control arm, this is the intervention arm. And the standard way of doing outcome in stroke is what is called as modified Rankin score, MRS. And essentially left is good, right is bad. So the MRS 6 is death. 5 is, as some people describe it, is it's worse than death. You wish you were dead, sort of thing. 4 is you need a lot of help. 3 is you need some help. 2 is you're independent, you can take care of yourself, but you probably can't go to work. 1 is that you just have very minimal disability. 0 is you're normal. So that is how the scoring system works. And as you can see, there's a dramatic impact in terms of number of people who get independent, and there is a mortality benefit as well. And this is another way to present it, and this is now how we present it to the patients in terms of that if you're in the medical treatment arm, 2 are dead, 5 have a bad outcome. If you are in the endovascular treatment arm, you save 1 life, 1 less person is dead, and 5 people have a good outcome. So the massive effect size. Of note here, just a bad disease, that in spite of this intensive treatment, still a significant number of people don't have a good outcome, which also suggests that there's a lot of scope for further improvement. And you don't have to change the paradigm of IVTPA. So in the trial, patients who were eligible for IVTPA got IVTPA, and there was still a benefit. There were patients who were not eligible for IVTPA, there was still a benefit. It doesn't matter whether IVTPA is given or not. And there was a mortality benefit, which is front-loaded, as would be expected in any surgical situation. And then you do all these subgroup analysis, and interestingly, all the subgroups showed benefit. And I'm not going to go into the details of all the subgroups, but just so you're aware that this is in NEJM, you can check it out. But essentially, even like, for example, patients over 80, there was still benefit. So it's not something that there's a certain age group or a certain sex or a certain kind of this thing where the benefit is there. So for example, this is over 80, there is still benefit, although if you're in the control arm, the mortality goes up big time, which is not unexpected. And I'm not sure what. And if you take the imaging subgroups, so for example, patients who have tandem occlusion, a cervical IC occlusion with an M1 occlusion, the dramatic benefit was really dramatic. If you take the aspect score, patients who have really good aspect score, patients who didn't have that good aspect score, the benefit is still there. So, not sure, something is goofed up with the colors here. So let me just see if I can, in the process of transferring over, I think it's saying something about the computer doesn't have enough memory to run the image. Anyway, we'll just deal with it. So the other trial, this was a slide showing the cover of the Swift Prime trial. That was the other trial that I ran along with Jeff Saber primarily. This was again a worldwide trial. This was also published in NEJM. And again, the inclusion criteria was very similar in terms of it was a typical randomized controlled trial. I don't know what's happening. The image cannot be displayed, saying it's not enough memory in there. So. So it says that there's not enough memory to display the slide. But anyway, we'll carry on. And okay. So anyway, so this was a sort of a similar kind of design, and taking patients with proximal vessel occlusion with significant stroke. But in this case, the trial design was slightly different because what we did was that we went to the FDA with the trial protocol, and we got a pre-approval of the protocol so that if the trial is positive, then FDA gives approval for the procedure. And the other difference was many of the patients had perfusion imaging done. And the main result was actually very similar. Patients had big bad stroke, NIH median of 17, and very good recanalization in the endovascular arm. Most vessels could be opened using the solitaire device. This trial was done in such a way because of FDA that you had to use one device. And solitaire is made by this company Medtronic, so Medtronic sponsored the trial. And this is again the main result, very similar to the ESCAPE result, dramatic benefit, MRS 0 to 2, and mortality benefit as well. And if you look at it, 60%, 35%, so again a 25% effect size, number needed to treat of 4. And this is not projecting very well, so because of the color change from transferring between computers. So this is the complication rate. So the complication rate of the procedure was extremely low in both the trials. And once again, this is not projecting very well. This was the forest plot where this column seems to have disappeared. But anyway, everything was towards the good side in which all the subgroups showed benefit of treatment. So this is sort of the background, which was I've shown you the results of the 2 trials that I ran, and there were a total of 5 trials, and all of them showed a similar kind of result. So, but the bottom line is, as a consequence, now endovascular treatment for acute ischemic stroke due to proximal vessel occlusion in the anterior circulation is now standard of care, which means that we as a collective have to develop systems. We have an obligation to sort of offer it to patients who fit that criteria. Now, obviously, there are many complexities in terms of sort of the overall big picture, economic complexities, workflow complexities. But the selection has to be done based on imaging and find out which patients are suitable for this kind of treatment. So from that point of view, I'm going to give you a little bit of a flavor of how to think about the whole imaging paradigm. So first part is that decision making in life is dichotomous. Any decision that you want to make, you have 3 choices: yes, no, or wait for more information. So for example, right now, Germany and France could get together and say yes to giving more loans to Greece, or they could say no to giving more loans to Greece, or they could wait for more information. But ultimately, if they wait for more information, the situation may implode, Greece exits the euro, and your decision doesn't matter anymore. So there is a time to a decision, and if you don't take a decision at a certain stage, not taking the decision is the same as a no decision. So this applies to any rapidly changing situation where in acute stroke, if you don't take a decision fast, it's the same as a no decision. You know that time is brain infarcts grow during the hyperacute phase. So I typically use this number, which is from a paper by Jeff Saver, 2 million neurons a minute. And this is very great in terms of sort of influencing workflow, 5 minutes, 10 million neurons. So it's a great way for pushing people to work faster, because if they don't do things fast and they delay by 5 minutes, you can tell them, okay, you just lost the patient 10 million neurons. The other part which is important to realize from this slide is this is an average. Currently, our technology doesn't allow us to determine in one particular patient is it 10 million neurons, 20 million neurons, 30 million neurons per minute. All you can do is work on averages, which is another reason to move fast and work fast. The only treatment that works is recanalization. You can do it intravenously or you could do it endovascularly. And unfortunately, the pictures are not showing up here for some reason. Should I run it off my computer again? Needed a reboot or something like that. So thanks very much. So this was the other trial that I ran, which is called Swift Prime, and this is